Okay, good evening, guys. Today I'll discuss about emerging topics in infertility. It's a Foxy guideline. Okay, in this, I want to discuss. It's a 2018 guideline of Foxy. Now I want to discuss about only these five topics. First is barriers to the infertility care in low resource setting. Then, if there is any unexplained infertility, how to approach that couple. Then, what are different ultrasound findings and endocrinology evaluation for the patients who are trying to conceive? Fourth, any fancy gadgets in total quality management of IVF. Okay. Fifth is absolute estenogenospermia, how to manage this case. Okay, we'll learn about that. First thing is barriers to the infertility care. Mm, So we all know that all the male factors are very important because male factors contribute almost one third to half of total infertility cases. Okay. Uh, there is infertility treatment in this whole world, but it is very less approachable. Only less than 1% of them are being using this ART clinics. Okay. Mm, and India is very prone for infection, mainly the tuberculosis infection, where there is damaged tubes and endometrium as well, which is one of the reason for infertility. Okay, so basically, as there is infertility, we need to educate people that there is a chance of artificial reproductive technique. Okay, and most of the couple they waste time in roaming with the quacks and underqualified doctors. So early referral to trained specialists is very important because it saves time. Okay, so WHO says that infertility is a global health problem, so it recommends that low cost ART should be given. So because IVF is very costly, right? So WHO recommends that as this infertility is a global health problem, it is better to give initiatives of low cost ART. There is a project known as Walking Egg Project. What is that? Walking Egg Project. This is for affordable infertility care and cheap laboratory procedures like fertilization culture are done at some low cost. Okay, so basically it's nothing like government should take initiatives like public-private partnership should be taken and insurance cover. So before they used to say that there is no insurance coverage for infertility treatment. Nowadays, government is taking initiatives to cover the insurance coverage for infertility care as well. Okay, that's about first topic. Second is how to approach a couple with unexplained infertility. See, very important. I like this line. If there is absence of evidence, is not evidence of absence. Okay, understood? If there is no evidence, if there is no reason for infertility, that doesn't mean that there is no mm, there is really no reason. Actually, there is a reason, but we couldn't see that. That is the thing. That it is line. Okay. So we all know that infertility is described as if after 1 year of unwanted intercourse or unprotected intercourse, then also they are not getting pregnant. That is known as infertility. Okay. Mm, See, unexplained infertility means we did all the tests, like test of ovulations are done, she's ovulating. Okay, then tubal patency done, HSG test is done, both the tubes are patent. Laparoscopy is done, dye test is done, both the tubes are patent. Even some analysis were normal. So male side, female side, male side, female side, both side are normal. Everything is normal. Even then, after that also they're not getting pregnant. That is one unexplained infertility. Okay, almost one quarter, okay, one fourth of the patients are suffering with this unexplained infertility. Hmm. uh, so I told na, even though it is unexplained, there can be some causes which we don't know. It can be because of immunology, genetic, reproductive physiology disturbances, endocrinology imbalance, that way. Okay, mild endometriosis which cannot be seen, tubal dysfunction, poor ovarian reserve, subtle defects in the sperm oocyte interaction, cervical function dysfunction, implantation, sperm functions. In that, if there is any disturbances, then also there will be unexplained infertility. So, for a couple with unexplained infertility, what should we do? What are the treatment options? Mm, mm, so, first thing is um, we should say there should be a time frame. Okay, there should be a reasonable time frame so that they can have a spontaneous pregnancy. Mm, see, availability of resources, age of the female partner is also very important. Um, or else if it is secondary infertility, then also we can think, okay. So people will say that if for an unexplained infertility, if duration is more than 2 years, or else if the female partner, if she is more than or equal to more than 35 years, okay, more than 35 years, then better go for treatment. Treatment means basically you should go for IVF, okay. Mm, female is 35 years and or else married life is, or else they're having unprotected intercourse for more than 2 years. Okay, so nice says that um, what you can say unexplained infertility means unprotected sexual intercourse for a total of 2 years. 2 years means for 1 year they started without any investigations. They're not getting pregnant. They started investigations. After that also they can try for 1 year. Even then they're not getting pregnant. Then better option is IVF. Okay. So women's age, ovarian reserve testing, these are very important. So um, see, even though the patient having regular cycle, do we need to give ovulation induction? See, she's having ovulation, she's having regular cycle. Even though that at that time, do we do ovulation induction? Then that question is a debatable one. Some people will give, most of the people will be giving. Okay. So if you see this success rate, like if you just wait and watch, or else if you go for clomiphene citrate plus diamond intercourse, then the pregnancy rate is versus if you see the pregnancy rate is mm, 1.03. Okay, in that way. If you go for expectant versus natural IUI, then it is 1.53. If you go for stimulated IUI, it is 0. If you go for mm, this thing IUI or national IUI 2.14%. Okay, in that way. So it is all debatable. That is, there is not that difference that if you wait and watch or if you ovulate induction, there is some good pregnancy. That there is not that kind of difference. Okay. Mm. So, what is a guide for treating the couple with unexplained infertility? If the age is less than 35 years, then you can go for expected management up to 2 years. Okay, or else you can go for 4 cycles of IUI. After that, follow that, you'll go for IVF. Okay, so you will wait for 2 years, then your IUI for 4 cycles. 4 cycles, remember that is very important. 4 cycles of IUI. If then it is not occurring, then go for IVF. If it's 35 to 39 years, you can wait for at least 1 year, then 4 cycles of IUI, then it's not done, then you go for IVF. If at any age and poor ovarian reserve, or else age of 40 years, then you go for time intercourse for only 6 months, then you can try for 2 to 3 cycles of IUI, then you can go for IVF. Don't waste time in old age people, okay? In that way. Mm. So, this guidelines, Foxy says that don't offer this ovarian stimulation agents like clomiphene citrate, letrozole to the woman with unexplained infertility. So this guidelines clearly says that don't offer ovulation induction. Because ovulation induction does not increase the chance of pregnancy or live birth. Okay, same thing. Uh, and moreover, with ovulation induction, there is side effects of multiple pregnancy, and there is threefold risk of ovarian cancer as well. If you use letrozole, clomiphene citrate for more than 12 cycles, there is a chance of ovarian cancer. This should be discussed with the patient. Okay. Um, Gonadotropins. See, some people will be giving gonadotropin support for unexplained infertility. Okay. This also depends because it is costly and patient convenience also should be discussed with the patient. Coming to intrauterine insemination. Mm, so, some people says that if you increase the density of the spermatozoa, then during ovulation, then there is chances of pregnancy. Some people say that the hypothesis, but it's not true. Some hypothesis is there. Mm, some says that uh, there is a what you can say there is difference in the live birth or multiple pregnancy rate in the couple when IUI was compared to time intercourse. Both with or without ovarian hyperstimulation. Understood? So if you go for IUI, then there is difference in the live birth rate or twins are more chances with IUI compared to time intercourse. So one Cochrane review says that. Okay. Mm, uh, some says that or there is optimal time interval between HCG and IUI. Okay, in that way. So, one meta-analysis concluded that double IUI offers no clear-cut benefit. This is very important. Last time NEET is this question. Double IUI, if you do, there is no clear-cut benefit over this what you can say couple getting pregnant. Okay, that's it. That's about IUI. Coming to IVF for ICSI. So in vitro fertilization could provide a solution for the couple. Okay, whatever reason, IVF can be a solution to unexplained infertility. Mm, okay, so if people have some social, cultural, religious objection for IVF, then even though they have that, then there is no need of wasting time with IUI. Okay, 2 years, let them try. Um, okay, if even though if it is not done, then you go for IVF. And one concurrent study in 2012 told that instead of going for IUI, better go for IVF in an unexplained infertility. Okay. Hmm. There is a fast trial. What is fast? Fast track and standard treatment trial. Okay. Sorry. So they say that there is a shorter time to pregnancy and there is high prevalence of there is a cost effectiveness of IVF. Okay, that fast trial indicates that IVF is better for good pregnancy risk. Mm, mm, some says that better go for IUI at least 4 cycles. Then you go if you go for IVF, then there will be a good reserve. Will be good reserve. Okay. Mm, and that's it. That's it about unexplained infertility. Third chapter is 3D ultrasound in endocrinology evaluation in case of this thing, infertility. So generally, for a infertile couple, you will for the mainly for the female couple, partner, you'll go for these tests: androgen, AMH, FSH, LH, estrogen, progesterone, thyroid, prolactin, insulin. So mostly we'll miss insulin. Sorry, mostly we'll miss insulin, but insulin is very important. Hmm. Coming to first hormone, androgen. Androgen is responsible for, see, in this ovary, you will have that preantral follicles, right? Preantral follicles. So this preantral follicles recruitment is done by androgen. Okay. Growth. These are growing like this, na. So growth depends upon androgen. More androgen follicles means more androgen that way. So there is a follicle number counter. So no AVC is the software. It have helpful to count the follicles. Okay. So there is a fluid filled follicles. I will count that. Okay. Um, the size of that follicles. If you see, if it is very good size, and depending on that only, we'll try to give FSH. Okay. Mm, increased androgen also leads to increased urinary resistance. Okay, okay. Next is anti-Mullerian hormone. Anti-Mullerian hormone is generally produced by the granular cells of the preantral follicles. All of these follicles are produced by means of androgen. So after the follicles are being produced, that follicles have granular cells which produces hormone is anti-Mullerian hormone. Hmm. So, how many small follicles are there? That much good antimullary hormone will be there. Okay. So, andro follicle count ovarian volume shows significant correlation with AMH. Hmm. Mm. And so ovarian volume can be calculated by means of software called vocal. Okay, understood? There are two softwares. One is number of follicles are counted by Sono AVC. Sono AVC is helpful to calculate number of follicles and ovarian volume. See volume for vocal. Remember volume for vocal is calculated by vocal software. So androgen is a cause for preantral follicles, where AMH is the effect after the free preantral follicles become. Um, AMH and ovarian volume provides direct measurements of ovarian reserve, whereas AMH inhibin B estradiol are released by growing follicles. So AMH or else estradiol all indicates a developing follicle count. Okay. Next hormone is FSH. So FSH is generally secreted by pituitary. Okay, its secretion is controlled by GnRH. Pituitary releases it, and its secretion is controlled by GnRH from the hypothalamus. Okay. Hmm. So if a follicle is beyond 6 to 7 mm, it indicates that there is a good action of FSH. Uh, mm, so, if follicle growth is more than 10 mm, if in ultrasound you have a follicle of more than 10 mm, that indicates that FSH is good. Instead of doing again FSH test, okay? Follicles are going 10 mm size, that means FSH is very good. In stimulated cycle, normal follicle growth rate of 2 to 3 mm a day suggests normal dose of FSH. Okay? Growth is good means FSH is good. Okay, the doses are considered to be low in case of slow and high in the faster growth. Okay, so if the growth is slow, that means FSH is low. If growth is very fast, that means high FSH is there. Okay, if you see this image, there are different follicles. So the number of follicles, one, two, three, in that way they gave a count. So this software is known as Sono AVC, which is done in if you see it done in 3D ultrasound, 3D ultrasound. Okay. Mm, Mm, so there is a stromal vascularity also you can see. Even on color Doppler, you can see stromal vascularity. It support androgen and FSH, AMH. Now coming to LH. LH is also produced by pituitary. It is secretion is also controlled by GnRH and positive feedback of estrogen. So LH is by positive feedback of estrogen, whereas FSH is by negative feedback of estrogen. Understood? So FSH negative feedback by estrogen, okay, whereas LH positive feedback of estrogen. That way, you remember that. So, um, so if you have more LH, elevated LH, which is in case of polycystic ovarian syndrome, there is more number of blood vessels. Okay, not only that, there is catecholamine stimulation, leukocyte, cytokine activation. Okay, uh, if you see this, the volume of ovary been measured. Okay, if you see, they're measuring the volume in centimeter cube, right? So volume is measured. So volume is measured by means of what software? Vocal software. Okay. Um, mm, if you see the peak systolic velocity of the ovarian vessel, they calculate the peak systolic velocity. If it is low in early follicular phase only, after immediately periods, after 5 days, if you see the peak systolic velocity, if it is low, that indicates that they are poor responders. Okay. So for patient have more LH, they have more vascularity, and they are better responder and then do not require any LH during ovulation induction. Understood? There is good LH and there is a good blood supply. There is poor LH, there is a poor blood supply, and they're not good responders. Okay. High LH in PCOS leads to exposure of the follicles to LH when they're still not dominant. So even though they don't become dominant, even in small phase only, high LH is seen. Okay. So conversion of granular cells to theca cells in dominant but not mature follicles. The more follicles are not mature, but there is conversion. So both these may be seen in patients with organ ovulation and leads to increase in stroma. So, so there will be delayed menses, and there is increase in stroma, ovarian stroma also. Hmm. So stroma is very high. More stroma, abundant stroma means it indicates there is high LH. Okay, if there is abundant stroma, that indicates there is high LH. Okay, stromal abundance indicates high LH. Uh, so even that volume can be calculated. So that's why in PCOS you will say if it is more than 10 centimeter cube. Why? Why I'm telling about volume? Because there will be more stromal abundance in case of PCOS because of high LH. Okay. So in pre-ovulatory period, increasing LH levels correlates with rising perifollicular PSV. Mm, okay. So perifollicular PSV is being raised. This means that in mature follicle, high PSV indicates that surge has already started. Okay. Premature LH surge. So generally, there will be a mature follicle. After that, dominant follicle is done. Then only if you have LH surge, um, then you'll get ovulation. But in case of PCOS, what happens is there is um, premature LH surge. Even though the follicle is not mature, and before only the LH surge occurs. Okay, so there is high RA, and in the perifollicular vessels there is high RA. So not only that, it acts on the cells and it produces androgens and progesterones from the cholesterol. Inadequate LH receptors or inadequate LH levels may lead to inadequate progesterone production and luteal phase. So as there is see, LH is very high, but there is inadequate LH receptors. Okay, because na, LH receptors should come out. They are inside. They should come out. Then only LH can act on that receptor. Because of inadequate LH receptors, there is inadequate progesterone and there is luteal phase defect. There is luteal phase defect. Okay, this is such as this leads to scanty corpus luteal vascularity and there is high resistive index. Okay. Um, if you see this image, there is luteinized follicles and there is hyperechoic walls. If you see the walls, there is white walls of the follicles. Okay, that's about LH. You understood now? LH is very important. High LH is in case of PCOS, and if there is premature LH surge, there is high resistance index. So everything is very high here. Okay, high LH, high resistive index, and that. Okay, coming to estrogen. Estrogen is generally produced by the granular cells of follicles, and it rising levels can be correlated with low resistance of perifollicular vascularity. Okay, even the endometrium thickness is because of estrogen. Cervical mucus is because of estrogen. Even the vascularity of the endometrium also because of estrogen hormone. Okay. Mm, if you see the ovulatory time, pre-ovulatory time, the endometrium, there is intra-endometrial flow, which is in the Doppler. Okay, and if you see it is the early secondary endometrium, it is growing. So, uh, so, yeah, if there is a low estrogen, if there is low estrogen, then there is high resistance on the endometrium. Okay, because if there is low estrogen, then because of immature follicles, it leads to scanty or high resistance flow in the endometrium. Scanty flow or else high resistance flow in the endometrium is seen. Okay, so because of LH, you can see perifollicularly resistive index high. Okay, because of LH, there is high resistive index, and because of low estrogen, if LH is high, resistive index is high, but estrogen it is reverse. If low estrogen, then there is high resistive flow in the endometrium. Okay, last hormone is progesterone. Progesterone, na, it after in early proliferative phase, endometrium increases because of estrogen. Okay, so after ovulation, the corpus luteum produces the progesterone. Okay, so pre-ovulatory progesterone rise can be seen on the endometrium also. This hyperechogenicity of the endometrium. Generally, progesterone is secreted by uh, corpus luteum, and that is also under influence of LH. Um, so, resistive index also we can see of the corpus luteum, which is adjunct to the plasma progesterone level, which is index of luteal function. So, same, even the progesterone is also same. If the progesterone is low, then the resistive index or resistive high resistance flow is there. Even that high resistance flow of corpus luteum, right? Even in estrogen also, if estrogen is very low, then there is high resistance flow in the endometrium. That way, okay. So low progesterone levels increase resistance on the spiral vessels. So conclusion is hormones and changes occurs day by day during the menstrual cycle thing, and there is morphological and vascular changes which can be seen. And assessing this by means of Doppler ultrasound, even volume ultrasound, and correctly interpreting helpful in managing the case. Okay. Um, Next, I'll tell you next video. Thank you.